participants. I'm most pleased to welcome you all to this webinar on pulmonary fibrosis, the recent developments. We only discuss some aspects, and for that purpose, we have very eminent faculty with us today. Professor Aman Sharma, Dr. Sajal Dhuria, Dr. Amit Mandal, and Aditya Jindal. I'm very pleased to welcome all the faculty for this meeting. Professor Aman Sharma, of course, is the professor of clinical immunology and rheumatology services in the Department of Internal Medicine, and his special interest is CTD-induced interstitial lung diseases and pulmonary fibrosis. Dr. Sajal Dhuria, one of my colleague again, he is an assistant professor in the Department of Pulmonary Medicine, again at the PGI Chandigarh, and of course his special interest is interstitial lung disease, in particular pulmonary fibrosis, and I think he has numerous publications and one of the pioneers in the field in this country. So, Dr. Amit Mandal is a senior consultant whom you all know. I think he is at the Fortis Hospital. Again, he deals with all kinds of pulmonary diseases, in particular pulmonary fibrosis and critical care and so on. Aditya Jindal again is a pulmonologist, pulmonary consultant. I think we'll have a very kind of knowledgeable faculty on this subject. Interstitial lung disease, although our subject is pulmonary fibrosis in particular, and looking after CTD-induced fibrosing illness and the hypersensitivity pneumonias, and then Dr. Sajal is going to talk on the management of these disorders with antifibrotic drugs in particular. And thereafter, we'll have a panel discussion to answer to some of the specific issues which arise after their talks. I'll request all the speakers to be brief because we have relatively less time for each talk, only about 20 minutes. So I'm sure we'll be able to finish in time. So without going into further details, I'll request Dr. Aman Sharma to talk about the CTD, the approach to CTD-induced CTD ILDs. Dr. Aman, please.
Thank you, sir. It's indeed a great privilege to be on the same panel as Professor Jindal and with my colleagues, Dr. Sajal and Aditya and Dr. Mandal. My brief is to talk about approach to diagnosis of CTD, and my perspective would be that of a rheumatologist, and to give you a bird's eye view of how do we really approach the CTD associated ILD, and give you a bird's eye view of how these individual conditions can be managed. So just give me, I think there is.
So you can use the arrow keys also.
Yeah.
Yeah.
So, yeah. So here we go. Basically, the CTD ILD makes a substantial chunk of interstitial lung disease. It is pertinent for all of us to pick up the soft pointers which might be there in patients who present with interstitial lung disease. And the connective tissue diseases, they are characterized by circulating autoantibodies, and also when there are systemic manifestations which are considered to be related to the autoimmune diseases, so which may cause the damage. So the specific CTDs which are associated with interstitial lung disease, it's a very exhaustive list. But towards your right hand side panel, The ones like ANCA-associated vasculitis, spondyloarthropathies, relapsing polychondritis, Behçet's, and even APLA, they are very rarely associated, although you might get these are just like once in a lifetime. And just for the sake of inclusion, I have for completion, I've included these here. But the ones which are more commonly associated are conditions like scleroderma, rheumatoid arthritis, inflammatory muscle diseases, lupus, Sjogren's syndrome, mixed connective tissue disease, and IPAF, which I'll talk to in some detail. So when we talk about interstitial lung disease in this setting of a connective tissue disease, so 3 clinical scenarios are possible. The first one is there is a established connective tissue disease, which we know, and there is an ILD. So the thing, life is easy there. The second is CTD, which presents for the first time as interstitial lung disease, which sometimes this might belong to a group what we call as lung dominant CTD. And then there are others. The third scenario is when there is interstitial lung disease and there are some features of autoimmunity, but not enough to give a unifying label of a given disease. So, you know, this is the least of the least complex of the scenarios. It might be clinically relevant, but many times it might just be radiological finding, may not have any clinical connotations. Whenever up against such scenario, we have to think about drugs like methotrexate and various biological response modifiers. One has to be sensitive to the drug. You know, a drug history is very important. What kind of drugs, especially for rheumatoid arthritis, there is a wide array of drugs which are available. And also we have to be thinking about infections when it so happens. I just to give you some brief, you know, I'm not going to go through the details, but these and many more drugs are there, and there are different types of associations which have been reported with different anti-rheumatic drugs. If you look at the prevalence and characteristics of CTD in different diseases, systemic sclerosis tops the list, which you know, up to 70 to 90% HRCT changes, and almost half of them will have moderate to severe interstitial lung disease over a period of time. And NSIP pattern is usually more common than UIP. It occurs mostly in the first 5 years of the disease onset. Nuclear ANA or SCL70 antibody positivity is associated, more so associated with severe interstitial lung disease. The other group which is more commonly associated with is inflammatory muscle diseases like polymyositis, dermatomyositis. NICP pattern is more common than UIP. Dermatomyositis is more commonly associated than polymyositis. Dermatomyositis is the one muscle disease which is associated with the skin rash. I think all of us are aware, but one needs to know a little bit more about an entity which is associated with anti-MDA5, which might have a skin rash but may not have muscle weakness. So which is what we call as amyopathic form, and it is associated with one of the most severe forms of interstitial lung diseases, which is called a rapidly progressive ILD, and which requires probably the most aggressive immunosuppression, or the combination of immunotherapy is required, and still hoping for the best because mortality is very high in such scenarios. The other is rheumatoid arthritis, the varying reports of prevalence. UIP we know is more commonly associated than NSIP, and then organizing pneumonia. Most of these patients are having seropositive disease. There is some association with smoking and is seen more commonly in males. Mixed connective tissue disease, there is a classical criteria. It is characterized by U1 RNP positivity. And again, like some of the other connective tissue diseases, NICP pattern is more common than UIP. And generally, the systemic sclerosis like clinical findings and autoantibody findings are there in this. Sjogren's, we all know, it is associated with NSIP pattern, has Sika symptoms, but the unique association is with LIP. And also, we have seen a couple of patients with lymphoma. One patient who my guru, Dr. Bhamri, used to treat, had a lymphoma within the lung, presented as a lung mass, but it was a lymphoma in a patient with Sjogren's syndrome. The patient used to come from Ahmedabad. So always consider lymphoma in the differential diagnosis. UCTD, well, very limited data. Again, any of these patterns can be there. NSIP more commonly than UIP. There are some features of RA, there are some features of systemic sclerosis. I think I'll just briefly talk about, I've already talked about UIP being more common, more dominant pattern, rheumatoid arthritis, organizing pneumonia, more commonly associated with the with inflammatory muscle diseases, and LIP is more common in Sjogren syndrome. But does it really matter to know if the ILD is associated with CTDs or not? Yes, it does matter, because the clinical outcomes, the therapeutic outcomes, or these, they are very different from CTD ILD as compared to idiopathic pulmonary fibrosis. So it is very important for anybody treating these patients with this lung disease to pick up the cues, because then there may be there is a very much, the outcomes are very much different. The other scenario is when CTDs present as interstitial lung diseases, 10 to 30% of muscle disease may first time present as ILD. So look, and the muscle disease is sometimes just a mild ache, mild fatigue, may not, over a period of time, it might develop into a full-blown muscle disease. So therein, it is important to pick up the cues. I'll quickly show you the photographs very soon. Occasionally, it might occur with RA, not very commonly, and rarely also with systemic sclerosis. So the challenge is when the CTD manifestations are subtle. The third scenario is some features, some autoimmune features, some clinical features, pathology and or radiology suggestive of connective tissue disease, CTD, and but they are not enough for us to give one unifying label. European Respiratory Society and ATS research statement talked about IPAF in 2015, and for us to make a diagnosis, there has to be a presence of interstitial pneumonia either on HRCT or surgical lung biopsy, plus we have to exclude all other causes, and there is no definite, we have different criteria to make a diagnosis of systemic sclerosis, diagnosis of different inflammatory muscle diseases. I think it is beyond the purview of this talk to talk about all those criteria. But we have to know that this doesn't really fit into any of those criteria, and there has to be at least one feature in two of the three domains, which are clinical domain, serological domain, and morphological domain. Clinical domain, you don't have to mug up all these. I'll show you the pictures. Briefly, mechanics, hands, fingertip ulcerations, polyarthritis, palmar telangiectasia, which are also associated with systemic sclerosis, Raynaud's phenomena, digital edema, and unexplained rash on which is Gottron sign. Various autoantibody positivities, like we do the screen with ANA, rheumatoid factor, anti-CCP, dsDNAs, Rho and La, and anti-ribonucleoprotein, anti-Smith, topoisomerase or SCL70, which I was told you with has a poor prognosis, and tRNA synthetase, PMSCL, and anti-MDF5. So morphologically, radiological picture or histopathological picture of the entities that we've talked about, or a multi-compartment involvement in addition to interstitial pneumonia, which is, I think this is what I want to draw your attention to, is unexplained pleural effusion or thickening, unexplained pericardial effusion or thickening, and unexplained even intrinsic airway disease either on PFT or imaging or pathology, or unexplained pulmonary vasculopathy. So what are the, Raynaud's, we are all aware, but patients may not give the classical history of first pallor and then bluish discoloration. Some of the patients might just give history of pallor. The other patients might give the history of only blue discoloration. And only few patients will give you classical history of first pallor and then followed by bluish discoloration, as we are seeing here. The other thing is, sometimes the skin thickening is only confined to the fingers. As you can see here, the best thing is try to pinch in between the IP joints. And if as you can see here, the skin is not being pinched as compared to here. The other thing that you should always look for is whether there is a pulp loss or there is a decrease in the height of this digit. These are other things which you should carefully look for. These are suggestive of systemic sclerosis more commonly. You can see there are these fingertip ulceration, there is sometimes pulp loss, and if this is very extensive, then you can have gangrene of the digits. The other sign which is associated with dermatomyositis, this is Gottron sign, or you can have papules here, or even here, when we call as Gottron's papules. I talked about MDA5. So if you have papules over the palmar aspect, like this here, or if you could see here, or if you could see here, this was the patient that we saw in the outpatient, and we immediately thought about And there was thought about MDA. This is MDA5. These are what we call as inverse Gauterons. And this has got a clinical association with MDA5 associated disease, the same we subsequently published in Rheumatology Oxford. So all keep an eye on these clinical signs. The other is mechanics hands. You have fissuring over the lateral aspect of the fingers, which over a period of time increases to involve the fingertips and the whole of the hands occasionally. This was a young boy who had dermatomyositis, and you can see very bad mechanics hands. This was juvenile dermatomyositis, and you can see the hands clearing up beautifully with therapy. The other thing which is associated with dermatomyositis, you can see this purple pink hue around the eyebrows here, around the eyebrows, you can see these here also. This is a classical heliotrope sign in our patient of dermatomyositis who had CA bladder. So these are the signs which one should always look for. This was again our patient which we got as a patient of dengue with thrombocytopenia and fever and rash. But this was a dermatomyositis with a heliotrope rash because of paraneoplastic manifestation. She had wheezing, she had respiratory failure, and she had ileal carcinoid associated with dermatomyositis, came with fever and wheeze. The other rashes, which these are very profound rash which spares the nasolabial fold. This is in SLE. This is again the malar rash, which classically spares the nasolabial fold. But if I could draw your attention to the fingers here in the over the knuckles, there is no rash, but in between the proximal and the distal interphalangeal joint, if you see the rash here and the fingers here, this is what you call as lupus hands. More aggressive rash, discoid lesion here, discoid lesion over the ear lobule. So to differentiate, this is a lupus hand, as I have told you, in between the proximal and whereas if you could see the subtle papules here, these are the Gauteron papules, and there is some Gauteron sign here. The other thing that one should look for is alopecia. Basically, one has to look for other things look for joint swelling, pain, morning stiffness, muscle weakness, and sicca symptoms. So the most important thing is when you up against the wall, try to build partnerships. And this is the landmark Calcutta test partnership. I think the pulmonologist should make a partnership with the rheumatologist. Why I say so is then pre-ILD clinical diagnosis of IPS becomes anti-synthetase syndrome, and you can see IPF becomes a UCTD. And you are well aware ILD not otherwise specific turns out to be vaginous granulomatosis. So the diagnosis changes when you include because it is beyond the purview of any single talk to give all these nuances which are associated with picking up. We rheumatologists have to pick up the clinical cues to making these diagnoses. And suspecting CTD and HRCT, I think Sir has told to quickly wrap up. So I'll just say that just quickly go through most of these. Systemic sclerosis with subtle reticular changes, PAH and dilated esophagus in systemic sclerosis, esophageal dysmotility, minimal reticular changes, JO1 with anti-synthetase. I think the pulmonologists are much, far greater, have knowledge than what we possess while interpreting these. These are, the cystic changes associated with LIP. Up to, as I said, up to 90% of patients with anti-JO1 disease develop interstitial lung disease, and anti-PL5 and PL12 have high incidence. And hyperferritinemia, this is associated with MDA5 associated rapidly progressive interstitial lung disease. Systemic sclerosis, there is esophageal dysmotility and GERD with increased age, male sex. And I think basically one has to look for the extent of the disease, whether there is presence of honeycombing, and there has to be these are the risk factors, diffuse disease versus anti-SCL70. I've talked about most of these things. How do we approach? There has to be a staging. We look at how much extent of the disease, less than 20%, while we're making treatment decisions. How much is the FVC? If it is less than 20% of the total area, or FVC is more than 70%, it's a limited disease. Beyond it is an extensive disease. Clinical approach is correlation between NSE pattern and biopsy is less robust. Surgical biopsy is not really preferred in CTD ILD, but in occasional cases where CTD ILD, you're not making a headway, then once in your lifetime, maybe you can do. we had a patient of suspected sarcoid with lung involvement, when going to various different institutions, coming from Nepal, eventually ending up with us. And once we did the open, Dr. Bambri ordered an open lung biopsy, it turned out to be a lipoid pneumonia. So it may, but that is the only that I can remember in 20 years that I've been here. So it's rare, and probably we have experts who can vouch for it more than what I can do. So again, a long list of autoantibodies. I don't want to, I just enumerated most of those. Just to say that probably you'll have to pitch in the rheumatologist here to really decipher and tease out the clinical relevance of positivity in a given clinical context. Again, it is not exhaustive list. There are various others, but I just wish to sensitize. I just don't wish to go into the finer details. I can just tell you that positivity of each can sometimes give us cues to the differential diagnosis as is listed here. You all are aware about anti-synthetase syndrome. Sometimes we can do the prognostication, look for cancer-associated dermatomyositis like TIF1 gamma, and we can look for other screens for association of mitotic diseases. So basically, that's where we are. And I think my domain is not to talk about treatment. So basically, the inner core is looking at dyspnea, cough, lung imaging, functional status and survival, lung physiology, and health-related quality of life. The outer core, as far as the outcome measure that we are looking at these days, is event-free survival. And the research agenda is, can we have a biomarker which can be determined, and development of CTD ILD related patient-reported outcomes. So these probably would have changed over the last few years, but we still need to go a long way before we can really wind up all this. With this, I would like to conclude that some connective tissue diseases are associated with interstitial lung disease. Clinical clues and lab investigations can help us in establishing the diagnosis. Combined team approach can result in better outcomes. I would really thank all the viewers, and also thank Jindal sir for this very wonderful opportunity that he's given me to share share my views on CTD associated interstitial lung disease.
Thank you very much, Dr. Sharma. I think that was a very lucid and concise talk. We'll have questions at the end of all the 3 talks. But I must say that the point made by Dr. Sharma, that the rheumatologists must be taken on board while deciding the approach to interstitial lung disease and its management. I think that need has risen manifold in the recent past. Well, we'll come to these issues.